Thank you for joining the second session of our new Coker ValuePath mini webinar series. It's a privilege to have you join us. Our topic today is technology. Hopefully you all got a chance to pre-submit your questions, but if not, you can submit your questions to me via email at sburnett@cokergroup.com after the presentation, and we will answer your questions. If you have questions related to future topics in this series, please be sure to submit your questions to me prior to those sessions. After today's presentation, if you would like more information on the topics discussed and how they affect your organization specifically, please reach out to me directly and we will coordinate a time for you to speak with one of our associates. The participant phone line will be muted for today's presentation and the materials will be emailed to you shortly after the conclusion of this session. The slides are also available to download as a handout in the GoToMeeting dashboard. You will see the presentation slides from the first session for download as well. Recordings for that session are available upon request if you missed the first session. Finally, as you exit the webinar, a brief survey will pop up and we would greatly appreciate your feedback on this presentation. Today's discussion will be led by Jeffrey Dagerpont, Senior Vice President in our technology. Please join me in welcoming Jeffrey.
Yeah, thank you very much, Savannah. And let me just start by saying that it's an absolute honor and privilege to provide you with some input and guidance on this topic that obviously is very top of mind and for many very good reasons. I'll give you my upfront disclaimer that that I am by no means an expert in all areas of MIPS and MACRA. I think like everyone else, myself included, we're all learning and evolving. So if any of you know much about Coker, within our organization we are broken into service lines, and as a result of that we work to our individual areas of expertise. So my role in the company is exclusively in the area of IT and healthcare technology. So the good news is you're going to have much more knowledgeable people from either the first one or actually I think the second one that's coming up is on finance and reimbursement. That will probably answer a lot more of the more relevant questions around how do you actually get paid and what's the financial impact of all that. So with that said, I will give a little bit of a high-level overview, not drill down too much into specifics because I really want to spend most of my time and focus on the technology, which will come towards the end of this. And as Savannah said, these are designed to be very short and very compressed bits of information. We recognize that you may have questions that you think of, and certainly we'd be honored to answer those. Just email them to us. So as you're probably well aware, this really is predicated. In fact, as long as I can think of, there's been initiatives around quality. In fact, many may even recall the very profound national report that I think was titled To Err as Human, where that report concluded that I think it was somewhere around 100,000 people die every year as a result of medical errors and mistakes, and that really brought into focus the whole quality issue. And just to kind of put that in perspective for a second, that is the equivalent of a 747 crashing every single day. So it's obviously a significant problem. Now, in fairness, there's not as many people going through our airline system as they do our healthcare system, but still a lot of people nonetheless, and a lot of improvement for opportunity. There's also been a lot of focus on our healthcare system. In particular, there's a lot of data out there that shows or demonstrates that we spend more than any other nation or country, and our outcomes and results are not that much different or improved. Now, in fairness, and I'm always quick to defend this because I like to point out that in many other countries they just don't treat. So it's kind of easy to have pretty decent outcomes and lower costs if you don't treat people. And maybe that's our problem. Maybe we do treat in ways that aren't always necessary or beyond where the means does not justify the ends. And so part of this program is largely predicated on trying to provide the most effective healthcare, best quality at the most cost-effective way of doing so. So it is to strengthen that and to promote improved outcomes. And so obviously there's some targeted focus around those initiatives, and there's going to be a heavy emphasis on data. And as you may have heard people say in the past, you can either come with opinions or you can come with facts. And I think, unfortunately, for many providers for many years, the payers have always had the upper hand with data. Unfortunately, they use mostly claims data, which was okay, I guess, but it never really told the full story. It only told what the doctor did, maybe not things they didn't do. Certainly all the things that you do all the time that don't get charged for, that you don't have a way of capturing, the endless amount of phone calls and guidance that you give the patients that's just part of the job that just kind of comes with it. So it's really designed to do more tracking. And so when you get into kind of the details of what to expect, and again, this is high level, this is going to be covered in much more detail, but think of MIPS as the effort to consolidate all the various initiatives that are designed around reporting, data collecting, PQRS, meaningful use, value-based program. Basically, all that's going to be combined into the quality reporting program, and that's going to exist in a myriad of repositories, health information exchanges, various ways that we will store and need to retrieve, and hopefully this will be designed in such a way that caregivers, because where I'm a little bit skeptical is all this is great, but I can tell you firsthand that if the information isn't at the point of care when it matters, that can be a major obstacle, because let's face it, doctors only have so much control. Once that patient walks out of the exam room, you know, at some point they need to be held accountable for following through, taking their medications, you know, all those things impact quality. So we have to figure out a way that we're tracking this in a way that not only holds doctors accountable, but also patients and consumers as well as payers need to be held accountable. So think of MIPS. In fact, most people today are really just preparing for this part, which is, do I have the right infrastructure? Do I know which programs? And there's scoring methods and going to be ways that they will adjust your reimbursement up or down depending on how your measures come out from MIPS. Now, MIPS is kind of a precursor to the alternative payment model. So to be eligible for one of the alternative payment models, you essentially have to achieve most everything that's within MIPS. You have to have the infrastructure, the quality reporting, and all that down. And then within the alternative payment models, there are a myriad of different criteria you can choose from. There's ACOs, patient-centered medical homes, and by the way, some of this is still evolving and being fine-tuned, but essentially the way I would think about this is that MIPS is the foundation, and alternative payment model is the pathway for getting compensated and paid for the program that you obviously select. And again, this is going to be covered in a lot more detail in the next session. So what we do know, as you've seen a common theme, is that it's a lot of data. So here's some questions that are pretty basic, and many of you may have already started asking this. Well, what data is going to be required? I can tell you firsthand, having been around a lot of IT systems, even the best of EMRs are only capable of producing what gets put into them. And so it's the classic saying, garbage in, garbage out, or if it's incomplete going in, it's going to be incomplete coming out. So one of the challenges that we have is how do we structure systems in a way that will produce the best outcomes or have the best information. And we've kind of been through this once already with meaningful use. If you think of meaningful use, it was a step in the right direction in that it created a lot of functionality. So for example, meaningful use required care coordination and patient communication. So what does that mean? Well, that meant that we had to have patient portals. So that's a good tool to facilitate interacting with a patient electronically. However, many vendors just simply created clicks and kind of raised their hand and said, okay, we have a portal. But was it a meaningful portal? Was it useful at the point of care? Was it physician friendly? Was there ease of use? Does the workflow through the entire system, is it enabling the doctor to be efficient? I mean, let's face it, while this is the future and where we're trying to head, as we speak right now today, virtually every doctor is paid based on production. And so a lot of these things to get you to where you need to be, if we're totally honest with ourselves, do create obstacles and barriers for productivity. And I don't say this to scare anyone, but 30% of the projects that I work on are oftentimes removing failed or defective EMR systems, ones that are not capable of meeting these requirements, one that we already know is going to have conflicts, ones that we know that the programming is not going to be sustainable for the future requirements. That's why you're seeing a big major shift in the industry from on-premise, uniquely designed for each customer, to cloud, web-based products. So that way, it takes a lot of the complications and heavy, cost and expense of trying to do it on a case-by-case, client-by-client, server-by-server basis. So you're going to have to really examine, and I would encourage you, if you haven't done so already, start scrutinizing your vendors very closely in this area, because we saw this with meaningful use. We saw this with ICD-10. We even saw it back when some of the original healthcare reform and some legislation that was passed, and vendors just weren't capable. And oftentimes when major changes like this happens, in fact, you can almost see it. There's a major change in, let's just take HIPAA, for example. Let's take ICD-10, for example. ICD-10, shortly thereafter, or even before it happened, spurred a lot of vendor mergers and products being commercially discontinued. Well, why was that? Well, those products couldn't meet compliance, and so they were dead in the water. It was game over. You say, what do you mean they couldn't meet compliance? Well, in some cases, the programming language couldn't support the number of digits, because ICD-10 had more digits than ICD-9, and so it would cost hundreds of thousands of dollars to rewrite code and all that. So every time there's something like this happens, you have vendors in the market are faced with one or two choices. They evolve with the market and they adapt, or they have to discontinue. And sometimes discontinuing doesn't mean they leave the market. They just might get bought or folded into products that are compliant. And so if you haven't done this already, and by the way, there's no cost to this, you can send me a copy of your contract, and I will give you some guidance and input on specifically language you need to have to make sure your system will meet these requirements. Because I just think, as a matter of principle, you're paying monthly support, you paid a lot of money for the system. My guess is you have a reasonable expectation that that product you spent all those thousands of dollars on will be compliant. And so I'd rather you know now than wait to the 11th hour to find this out. So here are some questions that you should obviously start asking yourself and asking your vendors. And then, of course, as you go through this next step, staff awareness. Well, what does that mean? Well, if your quality program is going to be predicated on capturing certain pieces of information, you're going to have to bake that into your workflow, and the staff's going to have to be aware of what's required. I personally think we may even see a shift back to more of the scribe concept, the leveraging the tools for that can help put structured data. There's certainly going to be a lot more emphasis on building systems designed specifically, because if you look at ICD-10, again, I'll use that as an example. In fact, we did really well with getting the codes. I mean, we just uploaded that, or, it was the EDI vendors helped with that. It was the clinical documentation piece that had to go along with it. So that had forced a lot of people to have to redesign their EMR systems accordingly. I suspect you're going to see a lot of the same thing in this case. So start talking to your vendors now, get things in writing, get your contract, and this is the perfect time to square up your contract. And the reason for that is, let's say you wait until it becomes a known problem later, then you will have likely given up your leverage to get the vendor to comply with such a request, because once the vendor recognizes they're going to be challenged in this area, chances are they're not going to put any guarantees in writing. So you have a better chance now than you will if you later run into issues. So when you look at Coker's ValuePath and kind of how we help navigate folks, as I said earlier, we have various service lines within our organization, and they all function in a very collaborative way, and we dovetail with each other. So these assessments oftentimes look at your organizations. In my case, I focus, as I said, on the IT side, but what I'm really looking for are your gaps. I'm not that interested in trying to redo, rip and replace, start all over. That's the last thing in the world you want to do. But what you want to find out is, what does your current state look like compared to your future state, and what are the gaps? And in many instances, the gaps are pretty easy to close. It may be that the product already inherently has the functionality. You just need to make some adjustments, new programming, new builds. There may be third-party products and solutions. Maybe your vendor doesn't offer a pop health product, and there's a product or partner that they work with. So there can be pathways for going forward through partners. It doesn't always mean that your vendor is at a dead end, but you do want to find out where those gaps are sooner than later and begin looking at that. And so it's a process where we start prioritizing what needs attention first. Where's the market going? Making sure you're fully aligned with the market. What are your capabilities? A lot of this stuff is going to require time to implement. It's going to take change in roles and responsibilities in many instances to get reporting right, to get our processes right, to get our workflow right. And so we really look to complete end-to-end, starting with what is the outcome that you want to achieve, what are going to be the little requirements necessary to be compliant and participate, and then work backwards from there. So that's the why. And of course the what includes, as I said, market assessment. We look at your reimbursement, how it applies there, what current contracts against what the likelihood of it would look. And there's models actually that we run to compare. And again, in the next webinar, you're going to get into the details of this, so I don't want to get ahead of ourselves or give any spoilers away, but they'll go into that. And then, of course, there's a recommended set of actions, both short-term and long-term, to help you make this transition very smoothly. And then the how, of course, is that there's typically, over a 2 to 6 week period, depending on the size, the amount of data. Some practices actually are pretty progressive. If you've already been participating in PQRS, patient medical centered homes, you've been on a certified EHR for years, maybe you're already involved in an ACO, we find that there's a lot fewer gaps in those instances versus practices that are just now waking up to the reality that this is happening. And I don't know all the details, but I hear the reimbursement swags on this can be pretty significant. It's, if your practice doesn't have a lot of Medicare, then you may not be that affected by it. If you have I would say, 30% or higher Medicare, it could be a pretty significant, you'll feel it in your bottom line. So it's definitely something you want to recognize. And of course, there's the professional fees related to this vary. And there are other things that smaller groups, because we work with clients of all size, in some instances, it could be nothing more than just a simple day on site to do a mini assessment to give you a list of your critical success factors that you need to start working on. For example, if you're not ready, at a minimum, at no cost, let us take a look at your contract, because definitely we want to make sure that you're not going to have any major issues or hurdles. And then from there, we can start remediating any problems that you might have. And that could be something you could easily do today in preparation for this. Other considerations, and these were things that came from the questions that you guys submitted on the first webinar. So if some are missing here, definitely submit. We'll answer them back in writing. But one of the participants asked about telemedicine, and we thought that was just an outstanding question because we got to looking into it to see how that might apply. And if you really think of what this really means, specifically when it comes down to care coordination, there are many parts of our country where there is big shortages of healthcare providers and facilities and places that we forget about those places a lot of times. And so we do anticipate that telemedicine, if you're part of these rural areas, will likely play a big role. So in many cases, it will enable us to deliver care in places where there are, in some cases, no caregivers. And we're predicting, it's not hard-coded in any regulations at this point, but that meaningful use may actually, or telemedicine may actually be a requirement, meaningful use. As you've noticed over time, they do add stuff as they go. Like the first year, the portal wasn't required, but the second year, it did show up, and it's now mandatory. I think data integrity, that was another excellent question. A lot of frustration in this area because IT systems, you put data in, it's hard to get it out. The format that they have it isn't the format that the register needs it. And so you really want to vet out some of these data integrity issues. Larger clients are even going as far as hiring data stewards or repurposing people to do data stewards. And the job of a data steward is to really constantly examine checks and balances, making sure data is going in clean and you're getting the right output that you want. Also, what's the integrity of the input? Is it consistent? Is it standardized? Is it, are you using certain tools that, I know doctors oftentimes have their own unique preferences of charting, but we're probably going to see more and more need to start standardizing. Otherwise, when you're negotiating your part of the shared savings and you have outliers, you don't want someone who's doing good quality work just not to be represented well with their data because they simply weren't using the same nomenclatures or the same standard. I give you an example of this, and this is an actual true story. An OBGYN up in Maine had participated in a PQRS program, and based on mostly claims data, which I said earlier. And based on claims data, this OBGYN had more cesareans than all of her peers that were also participating in the same PQRS program. So what do you think the payers naturally assume? You know, poor quality, not a good doctor, you know, you're always, you know, coming to the operating room late, so you're driving up our cost by all these cesareans. Well, would you believe, do you know what they forgot to mention as an important factor in her profile? And that is that she was a high-risk OBGYN physician. So as a result of that, she had more breech babies, more twins, more complicated cases. So it just kind of goes to show you how a little piece of information can really make a big difference. And this payer was on the verge of bouncing her off the contracts and the plans because they felt like that her quality was not as good as the other doctors. So it just kind of goes to show how important something that you know, how significant that little piece of information really was in her case. System design and intake, you want to make sure you have that well thought out. And then the last but not least, I've already covered this once, but this is a very important thing, and even if it has nothing to do with MIPS and MACRA, I would encourage you every time you go to reinvest, acquire new products, acquire new modules, I would get what I would call an acceptance criteria. Basically, it says you're entering the agreement with the vendor, but you're not fully accepting financial responsibility until conditions get met. Now, you might have to pay some, but you do want to structure a contract in a way that holds the vendor accountable to deliver as promised. And we've really, that wasn't always the case. I mean, we've actually learned that the hard way because in many instances, people did sign contracts in good faith. I mean, they saw the demo. It worked. I actually called clients and the references, and they said it worked. But then an upgrade came along, and all of a sudden it turned out to be defective. So, you know, did I have a warranty in there? One of the biggest disservices that I see vendors oftentimes will attempt to do is they will look at these major changes in reimbursement, and would you believe they will come up with a module. And that module is an add-on. You know, you got to have my PQRS module, or now you got to have my ICD-10 module. And, you know, you're thinking to yourself, well, doesn't your program inherently have to do these things? Isn't this part of being certified? So you want to make sure that inherent modules that are going to be necessary are included in part of your package, because let's face it, these vendors are out there promising that's the whole justification for buying their system. So I don't think they should be, you know, now there may be exceptions to that. If, let's say, the law requires every waiting room to have a kiosk. Well, I don't know if that's fair for a vendor to buy you a kiosk, but their program should inherently operate with a kiosk. So there may be some give and take there, but my main point there is you should have a reasonable expectation that the program functions in accordance to the guidelines. Interoperability, another area that trips people up a lot is, oh yeah, we're HL7 compliant, but then you find out you have 3 or 4 people that have to coexist. They're all on different version of HL7. They all want to, you know, they're pound the flesh out of you because they each want a fee for it. And, you know, one simple interface turns into $30,000, $40,000, $50,000, and you're doing that in multiple instances where you're trying to have interoperability. In some cases, these interfaces already exist, and the clients or the vendors just don't make you aware of it, and they want to charge for the same thing that's already written. Now, I'm not saying you should get this stuff for free, but there may be opportunities to reduce cost if you know these things exist. And that's another area where we can definitely give you some guidance and input. It's actually down quite a bit because there's not much green space left in the procurement side. Most everyone now, or at least 60-70%, have an EMR. But back in the day, we topped out at about $900 million a year in procurement. And by the way, I should have said this in the beginning, COCR has no financial ties or any conflicts of interest with any vendors. We don't work for vendors or represent them. We strictly work for clients and hospitals. But because we did get so much interaction with those contracts, we have a treasure trove of information as to what you should expect to pay how your cost compares. A lot of times, periodically, I'll just get calls from past clients, and we'll just call the vendor and get rate reductions because the rate has creeped up above market averages. So I'll be happy to compare what you're paying to industry averages. A lot of times it's nothing more than just getting the vendor. So it's not germane to this, but for example, a good strategy is you could hold your vendors to say 1% of the CPI for future increases. That makes it to where it prevents them from just escalating cost on you outside of your control. And then last but not least, I really want to make sure you have really good, fair payment terms and structured payment terms. And so what I mean by that is, you got to invest in this stuff, but I don't necessarily think it's fair that you make a big capital investment. Maybe you structure it to phase it in. Maybe it's a little bit when you start, another installment after they demonstrate that they successfully installed it, then more when you go live, then another installment after you test it. You can break this up in a way, much like if you ever built a house. I promise you, the guy putting the roof on the house didn't show up expecting a payment before the foundation was put in. And once the foundation went in, you inspected it, okay, now we can do framing. Then after framing, you can do the roof. So it's no different than any other major project. You don't want to give up your leverage by making these big capital investments before you know you're going to get what's been promised to you. So I think I'm right on the button as far as time goes. I hope this was helpful, informative. If there's something I didn't cover that you have a question, there's my email address and phone number. This is not on your handouts. I added this late. I didn't catch that. But if you want to jot down my email address from this slide, and like I said, send me a copy of your contract. I'll be happy to take a quick peek at it and let you know if I feel like you're adequately protected for future enhancements and compliance with these standards. It's a pretty easy ask, and the reason why I say it's easy is because we've worked with most of the vendors, and in most instances they have already approved that type of request. So it's just a matter of finding out who's out of compliance on that, and then we just submit the request. So it's not hard. Dr. Knight is your guy. He is leading this. He's our CMO. Unbelievable in terms of his knowledge and expertise. He's set up these models for major health systems, and this is what he does. I'm just fortunate to carry his bag and help him out, and like I said, my role's really focused on the IT side of this equation. And if there's anything I can do for any one of you, it would definitely be an honor and privilege. So thank you all very much.
Thank you, Jeffrey, for that presentation. Like you said, if you have further questions, feel free to email them to either one of us, and we will get your questions answered. Again, we would appreciate your feedback on this presentation through the survey as you exit. The slides to this presentation will be emailed to you shortly. Thank you for joining us today, and we look forward to having you with us for our next session in 2 weeks on the topic of finance and contracting. Thank you.